Hey, my name is Chris. Thank you for tuning in. Today I'm going to be going over my second REI paper. This is by Diamond et al. In 2015. This is called the AMIGOS trial. The AMIGOS trial was looking at patients with unexplained infertility and questioning if letrozole can be used for ovarian stimulation without reducing live birth rate, but being able to reduce the multi-gestation rate. This is coming from the fact that gonadotropins and clomid, though successful for giving live birth, have an increased frequency of having multi-gestation, which can cause a bunch of complications with NICU stays and such. The main findings from this paper were that though letrozole was able to reduce the rate of multi-gestation compared to gonadotropin, it didn't compare to clomid. And then secondarily, it actually had a reduced live birth rate compared to clomid or gonadotropin. My name is Chris. Let's dive into the paper. This is the AMIGOS trial. This stands for the assessment of multiple intrauterine gestations from ovarian stimulation. The ovarian stimulation agents they used were gonadotropin, clomid, or letrozole. The way they did the study was they took ovulatory women between the ages of 18 and 40 who had at least one patent fallopian tube and at least 9 ovulatory cycles in the past year with a normal intrauterine cavity and with a partner where they had a failed achievement of pregnancy within the past year. They consented 900 patients, so 300 patients per each of the group roughly. The primary outcome they looked at was multiple intrauterine gestation, and that was determined by heart rate between weeks of 4 and 6 of gestation. So jumping off into the stats, and this kind of confused me a bit, so I had to read a 2011 Diamond paper where he went over the stats for this one. But the way they looked at the stats was they actually only compared gonadotropin plus clomid versus letrozole. So it was either first line versus this new agent letrozole, aromatase inhibitor. The way they looked at this was they first did pregnancy rate. They said 30% was going to be for the gonadotropin and 27% respectively for clomid and letrozole. Then they said that roughly 30% are going to be lost for first trimester, which was found in the PPCOS2 trial, right? So 30% for minus for all of those. Then they said, okay, these are looking at multiple gestations. So then they looked at, okay, well, what do we think the multiple gestation rate is going to be for each of those medications? And they said 25% was going to be for gonadotropin. So out of these 70% that still remain, which live gestation after the first trimester, they thought that 25% of those were going to be multiples. When they thought about clomid, they thought 12.5%. And then when they did letrozole, it was 6.25%. And using those guesstimates from prior papers, they were able to then develop the number of patients they needed in the study in order to detect a difference. The difference was one-tailed, but I'm not going to really get into that. But that's roughly the statistics of how they went about this paper. Now we can jump off into results. And like any good NEJM paper, this is table 1. Table 1 is looking at your different comparisons between the groups. And what we're able to show from right here is that roughly the BMI and age is what I want to focus on. And they're roughly the same between both groups. We're looking at race a little bit afterwards. There's white, then black, and then Asian were there, and then mixed race and Hispanic or Latino. And then they had a few other indicators that they were comparing as well within table 1. But this is just to show us that roughly the 3 groups are the same so that any of the results that we're showing we don't think could be confounded by any of these prior baseline characteristics. And so here's the next table, table 2, and this is the big meat of the paper. And I don't want everyone to get confused, so we can walk through this table 2. Rate of clinical pregnancy, live birth, and pregnancy loss. So first we have to remember that the primary outcome they looked at was multiple intrauterine gestation. Not live birth, but gestation. And also what we have to remember is that when we're looking at the stats, the comparison that we're looking at is really only the far right column for the absolute difference. And that is when we combine gonadotropin or clomiphene and we compare that to letrozole. So if we look at the far right column and we look at the bottom kind of legend for this, we see that, the significance with the double S mark, which I actually don't know what it is called, but we can see that the clinical pregnancy among all women enrolled actually is statistically significant in the gonadotropin or clomiphene group versus letrozole, and it's 9.5. So that means that there was more pregnancies with either gonadotropin or clomiphene compared to letrozole. And then when you look at the live birth, which is, the next step after you get pregnant, was birth, was still 9.1. So even though they got pregnant, there still is increased rate of birth. The rest of the paper, the rest of these columns are interesting to look at, and you can compare like clomiphene and letrozole on the left side and kind of speculate. but the paper wasn't powered to detect the differences. The next part is a bit lower in this table, and that's looking at singletons, twins, and triplets. And this is because this is a multi-gestation question. So what we can see right here is we really want to look at, the far right column, and there's no significance because they clumped in the clomiphene. And when we look at the clomiphene, we show that clomiphene actually was really good compared to gonadotropin at not having multi-gestations. So the rate of multi-gestation in clomiphene was a lot lower. So the average, when you combine clomiphene and gonadotropin, it actually wasn't that much different than letrozole. So the clinical question in the paper was, did letrozole actually provide superior benefit for reducing the multiples? And compared to gonadotropins, yes, it did, but compared to clomiphene, it didn't. And this is kind of a little bit better documented on the next figures, where you can look at figure C and show that the comparison on the far right two columns was a P of 0.14, which is not significant. And the above section is looking at the time to conception and time to live birth. And when you remove the multiples, so twins and triplets, there was no difference when you combined gonadotropin and clomid versus letrozole. So those are the main results of the paper. So what is now the discussion really? So the question was, can we use letrozole in patients with unexplained infertility to get them to become pregnant? And you can, but the clinical rate of becoming pregnant with letrozole is a lot less than clomid or gonadotropin. So it's not a good medication for it. Though it did have a reduced rate of multiples compared to gonadotropin, it didn't have a reduced rate of multiples significantly when compared to clomid. So tying that all together, although letrozole did show some pretty impactful findings in the PPCOS2 trial, showing that it was equal, almost superior, right, to clomid in patients with PCOS and then managing their infertility, really when it compares to unexplained infertility, letrozole doesn't really have that same magic bullet. The study kind of proposes that maybe the mechanism as to why letrozole didn't have the same oomph as it did in the PPCOS2 trial was that maybe they might have a greater anti-estrogenic effect in patients with unexplained infertility compared to those with PCOS, which can then ultimately lead to altered hormone environments leading to suboptimal implantation. So I hope this paper helped kind of elucidate kind of a next step in really the REI pathway of infertility. If you have any questions, leave them in the comment section below, and I'll see you in the next video. Thanks.